You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 8th, 2024. This week, Plastics and Heart Disease, Bayes Theorem, the Mint Trial Letters to the Editor, and Brugada Syndrome. First, a quick announcement. Next week will be a Mandrola vacation week. I will see you next back in March 22nd. First topic today is plastics and heart disease. The New England Journal of Medicine published an observational study that explored potential linkage of microplastics and nanoplastics, but from now on in this podcast, just plastics, with cardiac events. This publication was a big event. Nearly 100 news sites covered it. It's all over social media, and I need not even say how ubiquitous plastics are in the world. The reason to explore the cardiac question is A, plastics are so ubiquitous, and B, there are numerous observational, preclinical, and animal studies that have suggested links of plastics to potential cardiac issues. Now, the mechanisms here are speculative and include things like oxidative stress, inflammation, and apoptosis in endothelial cells. This specific study authors from 3 centers in Italy. The first of many authors is Dr. Raffaele Marfella. They used an interesting design. They took resected plaque from patients who had carotid endarterectomy and then assessed them for plastics using biophysics, such as electron microscopy. Now, these were all asymptomatic carotid lesions, and an aside could be why asymptomatic carotids would have a carotid endarterectomy, and I've got a PowerPoint on that topic, and it's a good question. Some countries, like the USA, for instance, do a lot of carotid endarterectomy on asymptomatics, but other countries do very little. We're not getting into that debate today. The authors chose asymptomatic lesions in order to maximize the chances patients survive the post-procedure period, and also to minimize inter-patient variation in plaque phenotypes. They then followed 307 patients who had these carotid endarterectomies for future cardiac events. 257 of the patients completed follow-up. So they had 2 groups of patients. One group of 150 patients had plastics detected in the carotid plaque, and 107 patients had no plastics detected. The primary cardiac endpoint was a composite of MI, stroke, or death. The most common plastic was polyethylene. That was 58%, and 12% of patients had measurable amounts of polyvinyl chloride. The electron microscopy pictures, which the authors shared in the paper, show these jagged-edged foreign particles. Now, over 33 months, the main finding of this paper was that patients who had plastics detected were at a higher risk for a primary endpoint than those in whom these substances were not detected. The hazard ratio was substantial at 4.53. The 95% confidence intervals went from 2.00 to 10.27, and the calculated p-value was less than 0.001. And I know this is a huge effect size for cardiac events. To support the causality, the authors told us there were also increased levels of 4 inflammatory markers in plastic-positive patients. So, in sum, this observational, non-random comparison study combined biophysics with epidemiology. Like many observational studies, there was an attempt to compare groups and assess causality. Of course, the authors say this was just an association, that the study cannot prove causality, but like many studies like this, these words are sort of just a veneer. The real purpose, as expressed in the conclusion, were that patients with plastic detected had higher rates of cardiac events. Now, the New England Journal of Medicine also included in the same issue an 80 reference review article and a pretty scary editorial. That review included all the things that can be done to limit exposures to plastics. The lead in the conclusion of the review article, quote, "There is an urgent need for the clinical community to address the growing burden of exposures to these chemicals, largely derived from petrochemicals, in order to prevent a broad range of associated health harms." And then this, quote, "In addition to counseling their patients, clinicians can be critical advocates for policy changes to both decarbonize and detoxify the economy in order to address the combined health threats of petrochemical-derived EDCs and climate change." The editorialist, Dr. Philip Landrigan, wrote that, quote, "The report by Marfella et al. Provides evidence that microplastics and nanoplastics are associated with cardiovascular disease outcomes in humans, and, quote, the finding of microplastics and nanoplastics in plaque tissue is itself a breakthrough discovery that raises a series of urgent questions." All right, my comments. As you all know, I am not an expert in biophysics. I approach this problem as a skeptical, not cynical, appraiser of evidence. And I want to start by saying clearly that it is surely plausible that plastics could have a causal role in atherosclerotic disease. I worry a lot about these exposures. For instance, don't forget that at ACC in April, we are going to learn the results of the TACT-2 trial of chelation to remove heavy metals in diabetic patients. The positive signals from the TACT-1 trial was met with great skepticism because heavy metals are not thought of as a typical risk factor for vascular disease. And if TACT-2 is positive, not only will we have a new therapy in diabetes, but more importantly, we may have discovered a heretofore unrecognized cardiac risk. My point in this TACT-2 discussion is that the ubiquity of endocrine disrupting chemicals in our lives makes it a potential black swan-like risk. If you told me 10 years from now that plastic exposure was a health risk, I would not be surprised. But, double but, this paper should not move our prior feelings about the risks of plastics. Scientifically, it is a terribly limited analysis. The authors mention some of these limits. Why the editorial did not mention these limits surprises me greatly. I ask, where were the editors here? Aren't editorials supposed to be like the sober judges in the room? These were a highly selected group of patients from Italy. There is no mention on how patients were screened and recruited. Second problem, there were an extremely small number of events, and I don't care what the p-value was. There were 2 versus 10 non-fatal MIs. That means there's just a huge chance of noise here versus signal. And speaking of noise, Table S3, which depicts the regression of variables for the primary cardiac outcome, reveals what I think is the fatal flaw of this paper. Okay, the authors tell us the presence of plastics yields a hazard ratio of 4.5, almost 5 times risk for cardiac events that is statistically significant by the confidence intervals. Yet, the presence of known cardiovascular disease does not increase the risk of cardiac events in the next 3 years in these patients. The hazard ratio here was only 1.65, and confidence intervals went from 0.8 protective to 3.4. Also, LDL cholesterol is protective in this analysis. The hazard ratio for that was 0.96 with confidence intervals that went from 0.93 to 1.00, so significant. So I'm sorry, a 5x risk of cardiac events is way too large an effect size in a study where having heart disease does not increase the risk. Now the other issue, if plastics are so ubiquitous, why don't all the plaques have detectable plastics? Why only in 58%? The authors in their paper describe the possibility of things like lab contamination. They say that they don't have socioeconomic data, and there's a possibility of residual confounding. But of course, these are all listed in the last paragraph of the discussion. My friends, the purpose of critically appraising this paper is multifold. First, it's a good educational exercise. I learned a lot from doing it. Maybe you do too. Second, the proposed policy changes scare the heck out of me. In the editorial and review article, I did not see much mention about the negative externalities of changing society this much. I mean, think about it. Rich people will have no major issue changing the glass containers for their food, but what about the cost of shipping all these much heavier containers? And one of the main plastics exposures is IV tubing. Are people proposing giving less medical care? Dr. Tracy Woodruff, who authored the review article, concluded by saying clinicians can be critical advocates for policy change to decarbonize and detoxify the economy. I find this a shocking leap from a flawed observational study in 250 Italian patients' carotid disease to a major policy change. And what exactly are doctors supposed to tell policymakers? I have no idea how to decarbonize and detoxify the economy without creating billions of dollars in potential waste and possibly massive societal harm. I mean, I just wonder, have smart people and journal editors learned nothing from previous policy mistakes? Say, for instance, the hospital readmission penalties, which may actually be increasing mortality. Or even more obvious, the prolonged school closures during the pandemic, which nearly everyone now agrees caused immense damage to young people, especially the most vulnerable young people in society. Look, the Italian authors performed a modest study. It's a start in understanding the potential role of plastics in vascular disease. I equate it to the first half mile of a marathon. To say more about this study, to even suggest major policy changes is foolish and, to be honest, a trust shredder. All right, second topic is Bayes Theorem and Mint trial letters to the editors. I really had fun with this. I hope you do too. New England Journal of Medicine published 2 remarkable letters to the editors this week, and perhaps an even more remarkable author's response regarding the liberal versus restrictive transfusion strategy in patients with acute MI and anemia trial. I present this topic because it is an amazing chance to learn, because I am not sure myself how to think about the Mint trial. Recall first that the Mint trial enrolled about 3,500 patients with acute MI who had anemia. The liberal transfusion strategy with transfusion less than 10 grams of hemoglobin versus a restrictive strategy that required a hemoglobin of less than 7 to 8 grams. Obviously, more blood was transfused in the liberal arm, and the mean hemoglobin in that arm was 1.3 to 1.6 grams per deciliter lower in the restrictive arm. A primary outcome event, MI or death in 30 days, occurred in 295 patients, 16.9% in the restrictive strategy group, and in 255 patients, or 14.5% in the liberal strategy group. So that's 40 more patients had a primary outcome event, an absolute risk increase of 2.4%. Here are the statistics. The risk ratio, modeled with multiple imputations for incomplete follow-up, came out with a risk ratio of 1.15, or 15% higher. The 95% confidence interval ranged from 0.99 to 1.34, and the p-value calculates at 0.07. The 2 components of the primary outcome, death and MI, had similar relative risk ratios. Risk ratio for death was 1.19, and risk ratio for MI was also 1.19, and again, the confidence intervals were similar. Now pause there. There were higher rates of both composite endpoints, but both with confidence intervals ever so slightly below 1. 1 means no difference, and below 1 means better. The p-value, otherwise known as the surprise nature of the results, given the hypothesis that there were no differences between the strategies, was low at 0.07, but slightly higher than the accepted threshold of 0.05. So the New England Journal of Medicine had the authors write this conclusion. Quote, in patients with acute MI and anemia, a liberal transfusion strategy did not significantly reduce the risk of recurrent MI or death at 30 days. However, they add potential harms of a restrictive transfusion strategy cannot be excluded. Now, the problem with all this hedging is that when you, the clinician has a patient with an MI and a hemoglobin of, say, 8.2, you have to make a decision to transfuse or not. A p-value of 0.07 is one consideration, but so is that there were 40 more primary outcome events in the restrictive strategy. And the upper bound of the 95% confidence interval included a 34% higher rate of death or MI in a month if you don't transfuse. So let's get to the letters to the editor. Which letters to the editors both address the above sort of cloudiness of these results. One was from two French authors, Drs. Chapelain and Aubin, and I apologize if that's not the right French syntax. These authors wrote about the tension between the lack of significance and a 15% higher rate of death or MI with a restrictive strategy. They noted that the reverse fragility index represents the number of events that would have changed a non-significant result into a significant one. And they wrote that in the MINT trial, if two additional patients among the 1,749 in the restrictive strategy group had had a primary outcome event, or two additional patients among the 1,755 in the liberal strategy group had not had a primary outcome event, the results would have been significant in favor of the liberal transfusion strategy. This calculation shows how fragile was the lack of significance in the MINT trial. I like the fragility index, but I will also tell you that purists find it unnecessary for two reasons. A, because proper understanding of the p-value renders the fragility index obvious, and B, it assumes that reaching a 0.05 level means anything different from 0.07. The second letter from three Missouri authors, the lead author, Dr. Mirza Khan, presented a Bayesian reanalysis of the MINT trial results. Recall that Bayesian analysis of trials is just like we do with medical tests, such as stress tests. In a stress test, we multiply the prior belief, low or high risk, by the test results, which is the likelihood ratio, to come to our posterior belief. So a positive test in a patient with a super low prior risk may not cause your posterior belief to change regarding the probability of coronary artery disease. It's the same as the famous breast cancer mammogram example. Dr. Gerd Genzerenzer gave this question: what is the probability that a 50-year-old woman with a positive mammogram has breast cancer? Now, you were told that the incidence of breast cancer is 1%, which of course means that 99% of women do not have breast cancer. So the prior in this case is 1%. You were told that the sensitivity of the test is 90% and the specificity is 91%. So that kind of seems like a great test. Gigerenzer then asked this question to a bunch of doctors, and most gave the wrong result. Most doctors said the probability was 90% of having cancer, which was way off. It's not 90%, it's actually 10%, and it's important to understand why. Tests and trials don't tell you the answer if someone has a disease or not. Instead, they update your knowledge or belief. In the case of the mammogram, 90% sensitivity and 91% specificity, it gives a likelihood ratio of about 10. Likelihood ratio is roughly the true positive, or sensitivity, divided by false positive, which is 1 minus the specificity. Or using the numbers that Gigerenzer gives us, 0.9 for true positives and 0.091 for false positives, and if you divide those, you get about 10. So, if you multiply the prior 1% incidence, or 0.01 times the likelihood ratio of 10, you get about 0.1 or 10%. That was the right answer on the Gigerenzer question. I present this example to explain why the prior matters so much and how we interpret test and trial results. I hope you also noted how hard it is to screen for low incidence conditions, because even with highly accurate tests, like the mammogram, the majority of positive tests are false positives. Anyways, back to the MINT trial and the letters from the Missouri docs. They offered the same Bayesian reanalysis, and this allows to detect a probability of benefit, the likelihood ratio given the data. They then multiply that likelihood ratio, or the data, times 3 different prior beliefs. They used a non-informative belief, a skeptical belief, and an enthusiastic belief, and they presented this with graphs in New England Journal. In the non-informative prior, you are basically plotting the results as they are. And when I say plotting, it means drawing a bell curve-like probability density function. This allows you to predict the probabilities of any harm from the restrictive strategy, or whatever harm you choose, say 5% harm or 10% harm. In this case, the probability of any harm, a risk ratio greater than 1, was 94%. Okay, when they chose a skeptical prior, that is a curve centered on a relative risk toggling around 1, then the probability of harm is less. It drops down to 91%. However, if they use an enthusiastic prior, that is a belief that the restrictive strategy is harmful before even going into the trial, the probability of harm goes to nearly 100% given the data in the MINT trial. There are these nice pictures in the letter, and they write, quote, "In sum, the trial provides evidence that a restrictive transfusion strategy has a high probability of causing harm in patients with myocardial infarction and anemia." But the best part of this story may be the author's response. Basically, the authors agree. They don't say this, but one can imply that the New England Journal of Medicine required them to stay in the box regarding strict verbiage stemming from the rules of null hypothesis significance testing. They say that both the fragility index and the Bayes analysis basically argue for adopting a liberal transfusion strategy for these patients. I'm torn about this because to me, the MINT trial showed that a restrictive strategy looked harmful relative to liberal transfusions. And of course, there's going to be a trade-off because blood products can be in short supply, but from a single patient perspective, it looks beneficial to have a liberal transfusion strategy. But I'm also sensitive to some that argue Bayesianism can be dangerous because you can make non-significant results seem positive. A drug company or device company, for instance, that does a trial and the results do not make significance, despite proper power, they could run a Bayesian analysis and they might find a 60 or 70 or 80% probability that the drug is beneficial and sell that as positive. I am not saying I have the right answer here, only that overly restrictive binary conclusions from trials seem fraud. Please do weigh in on this discussion. All right, final topic today is Brugada Syndrome. The European Heart Journal has published a nice observational study of 370 patients with Brugada Syndrome who had implantable loop recorders. This was a multi-center study throughout Europe. They followed the patients for about 3 years. I like this analysis. They do not make any causal conclusions, nor do they make any non-random comparisons. Instead, they provide nice descriptors of what happens to patients with Brugada syndrome, which is a common question, especially for those of us in U.S. centers where Brugada syndrome is uncommon and kind of scary, actually. The authors were careful about making the diagnosis of Brugada syndrome. They had to meet ECG criteria. Here is a summary of the findings, basically. These were young patients, about 43 years old, 33% female, 60% had a proband status, about a third or 30% had a family history of Brugada, about a third had a typical SCN5A variant, and half of these patients had syncope as a symptom, 22% had palpitations, and about 25%, or 1 in 4, had no symptoms. So you kind of do have two groups, those implanted for symptoms and those who had no symptoms. So ILR implantation in symptomatic patients with Brugada syndrome did identify an arrhythmic event in nearly 30% of patients. And of those 30%, it had significant clinical implications in about 70% of them. The majority of detected arrhythmias, however, were bradyarrhythmias or atrial arrhythmias, while the rate of sustained ventricular arrhythmias was very low. The syncope pictures were nice. True arrhythmic syncope is infrequent in patients with unexplained syncope and Brugada syndrome, and it's mostly caused by bradyarrhythmias. Specifically, 77% of the Brugada syndrome patients in this study who had syncope had no arrhythmia. 77% had no arrhythmia on the loop recorder. That to me is an important finding. And only 8 of the 32 patients with arrhythmia and syncope had a VT. Most of the patients were bradycardia and atrial arrhythmias. The authors add that the yearly incidence of fatal VT in Brugada syndrome who do not have an IC indication is quite low at 1.1% per year. This is really important, as the authors discuss, because syncope in Brugada syndrome often triggers an ICD. But previous studies in patients with ICDs in this group have shown low appropriate shock rates and substantial rates of inappropriate therapies. This data certainly refutes guideline recommendations to use an ICD as syncope as an indication, because most syncope and Brugada syndrome in this study had no arrhythmia, and the arrhythmia that did occur was mostly not ventricular arrhythmias. Symptom status can be used to guide loop recorder implantation. Of course, that's because the detection of significant arrhythmias in asymptomatic patients was very low. 89% of loop recorders that were put in patients without symptoms found no arrhythmia, and only 4% found Brady and 7% found atrial arrhythmias and no ventricular arrhythmias. This paper is open access and I think worth looking at. First author is Marco Berganti. The more I look at Brugada syndrome, the more I worry that we overtreat many of these patients. So that's it for this week in cardiology. Remember, next week is a holiday for me, and I'll see you back on March 22nd. Thank you for listening. Remember, if you like this podcast, please take the time, give us a rating, write us a brief review. If you have something to add or something you disagree with, go to the website and write a comment. I enjoy learning from these comments. Until March 22nd, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.